High-frequency oscillatory ventilation. Disclaimer. Please consult the policies and procedures at your institution before initiating high-frequency oscillatory ventilation, as this video is just a guideline for learning.
Objectives, indications, settings, patient population. High-frequency ventilation is a type of mechanical ventilation which utilizes a respiratory rate greater than 4 times the normal value, and very small tidal volumes. High-frequency ventilation is thought to reduce ventilator-associated lung injury, especially in the context of ARDS and acute lung injury. This is commonly referred to as lung protective ventilation. There are different types of high-frequency ventilation. High frequency is often used in premature neonates with respiratory distress syndrome who fail to oxygenate appropriately with lung protective setting of conventional ventilation. It has also been used in ARDS in adults, but 2 studies, the OSCAR and Oscillate trials, showed negative results for this indication. The high-frequency oscillator uses active exhalation, delivers small tidal volumes, respiratory rates from 300 to 900 breaths per minute, which are represented as hertz on the ventilator. It is lung protective. Exhalation by electronically controlled piston diaphragm. Some indications include the following: ventilator-associated lung injury, alveolar hemorrhage, ARDS, refractory hypoxemia, persistent pulmonary hypertension, meconium aspiration, failure of conventional mechanical ventilation. Some contraindications include the following: higher thoracic pressures, right ventricular preload, pneumothorax, bronchospasm, barotrauma, intraventricular hemorrhage. The CareFusion 3100A and 3100B are similar in all aspects except the target patient size. The 3100A is designed for use on patients up to 35 kilograms and the 3100B is designed for use on patients larger than 35 kilograms. Unlike the 3100A, the 3100B does not have a mean pressure limit dial. Here is an illustration of a patient circuit. Next, we will examine the different hi-fi settings. It is important for the clinician to know which settings affect oxygenation and which settings affect ventilation. High-frequency settings and measurements. Mean airway pressure, delta P and amplitude, percent inspiratory time, frequency, bias flow, mean pressure adjust. Mean airway pressure, the primary variable affecting oxygenation, is set independent of other variables on the oscillator, can be viewed in a manner similar to the PEEP level in conventional ventilation. Here we see the mean airway pressure represented in the upper left-hand corner. Mean airway pressure is adjusted and controlled by the 2 knobs highlighted on the right side of the screen. Delta P and amplitude. Amplitude and power. Power setting is set as amplitude to establish a measured change in pressure. Delta P determines the amount of power that is driving the oscillator piston forward and backward, resulting in an air volume, tidal volume, displacement. Appropriateness of the power setting is determined by observing the chest wiggle factor. Chest wiggle should be visible from the level from the clavicles to the mid-thigh or the 8th or 9th rib. Increased amplitude will generate an increased chest wiggle. Chest wiggle should always be reassessed after positional changes. If chest wiggle factor is diminished or absent, consider decreased. Pulmonary compliance, endotracheal tube disconnect, endotracheal tube obstruction, or severe bronchospasm. If the chest wiggle factor is unilateral, consider endotracheal tube displacement, right mainstem, or pneumothorax. Clinicians must be proactive and monitor patients closely during the use of hi-fi via oscillator. On this screen we see the amplitude or delta P displayed as 35 and the power dial which controls the degree of piston deflection. Percent inspiratory time. determines the percent of cycle time the piston is traveling toward, or at its final inspiratory position. The inspiratory percent range is 30 to 50%. The default is 33%, which is most commonly used, but may change with changes in frequency. The percent inspiratory time is controlled and read here. Frequency. The frequency setting is measured in Hertz. Setting ranges from 3 to 15 Hertz. 1 Hertz is equal to 1 breath per second, or 60 breaths per minute. Example, 10 Hertz equals 600 breaths per minute. On this screen we see the frequency or Hertz is set to 6. Bias flow. Rate of continuous flow of humidified blended gas through the patient's circuit. Adjusting the flow can increase or decrease the mean airway pressure. Start with 15 to 20 liters per minute. Mean airway pressure adjust. Adjusts the mean airway pressure. Used to adjust when the following settings are changed: frequency/Hertz, percent inspiratory time, power, and delta P, piston centering. Here we see an illustration of the piston diaphragm, which is used for active exhalation. In this picture we see how we monitor if the piston is centered. The piston must be centered to properly achieve optimal hi-fi settings.
Alarms. High pressure alarm should be set to 5 centimeters of water pressure above set mean airway pressure. Low pressure alarm should be set 5 centimeters of water pressure below the set mean airway pressure. It is best to consult the institutional protocol for high frequency alarms, as these alarm limit values will vary accordingly.
The primary variables in achieving optimal oxygenation are mean airway pressure and FiO2. Mean airway pressure is a pressure used to optimize lung volume and, thus, to increase the alveolar surface area for gas exchange. In turn, this directly affects the PaO2. Mean airway pressure should be utilized to recruit atelectatic alveoli while preventing derecruitment. Although the lung must be recruited, this must be done conservatively to avoid overdistension. Alveolar atelectasis or overdistension can result in an increase in pulmonary vascular resistance. To initially introduce mean airway pressure, it should be set 3 to 5 centimeters of water pressure above the corresponding mean airway pressure used prior during conventional ventilation. Mean airway pressure normal ranges are 25 to 30 centimeters of water pressure. Adequate lung expansion is accomplished by the visualization of the 9th posterior rib above the level of the diaphragm. As mean airway pressure increases, the volume in the lung increases and the patient's diaphragm is displaced downward. Placement of the diaphragm via chest X-ray usually correlates to an acceptable PaO2. The mean airway pressure should not be reduced during the first 24 hours to permit an adequate amount of time for alveolar recruitment. The FiO2 is titrated by a blender attached to the oscillator. If the patient is over-oxygenated, the FiO2 and/or mean airway pressure should be decreased. If the patient's PaO2 is low, the FiO2 and mean airway pressure should be increased to increase oxygenation.
The primary variables in ventilation are tidal volume, chest wiggle, and frequency. Amplitude can be adjusted by the power control. Adjusting the power control regulates the amount of piston displacement by changing the amount of power going to the piston and the backward-forward movement of the piston. The degree of deflection of the piston, amplitude, determines the tidal volume. As the amplitude increases, the pressure gradient increases and, therefore, the tidal volume delivered to the patient increases. The increase in amplitude depends on the resistance the piston must work with to move forward. If the patient has low lung compliance, the piston must work against a greater pressure, resulting in less change in tidal volume. The same can be said for a patient with high airway resistance. If the patient is underventilated and the arterial carbon dioxide level is high, the amplitude should be increased to blow off more carbon dioxide. If the patient is overventilated and the carbon dioxide level is low, the amplitude should be decreased to allow less carbon dioxide to be blown off. The normal amplitude is set between 20 and 30 in neonates, with settings up to 90 centimeters. Water pressure possible. Appropriateness of the power setting is determined by observing the chest wiggle factor. Chest wiggle should be visible from the level from the clavicles to the mid-thigh or the 8th or 9th rib. Increased amplitude will generate an increased chest wiggle. Chest wiggle should always be reassessed after positional changes. In HFOV, frequency is derived from Hertz that controls the time allowed for the piston to move forward and backward. There is a resonance frequency of the lungs in which optimal ventilation, through carbon dioxide removal, occurs. Resonance frequency varies based on lung size, the degree of lung injury, amount of lung function, type and extent of the disease state, and the size of the patient. Gas transport becomes dependent on tissue inertia rather than elastance. If there is a disturbance of normal gas flow, VQ mismatch exacerbated by hypoxemia and worsening respiratory acidosis will occur. To overcome the effects of the resonance frequency, clinicians can optimize ventilation by providing the correct frequency. Reducing the frequency causes greater volume displacement, resulting in a greater tidal volume and subsequent minute ventilation. In conventional mechanical ventilation, the respiratory rate is increased to blow off carbon dioxide, but HFOV operates in opposition to this. To decrease the carbon dioxide, the frequency should be decreased. If the patient is overventilated, the frequency should be increased.
Inhaled nitric oxide is used increasingly in the care of infants with hypoxemic respiratory failure and is frequently combined with high-frequency oscillation. In this slide we see the clinical indications for hi-fi oscillator versus high-frequency jet ventilation. High-frequency jet ventilation can also be effective in pre- or postoperative congenital cardiac conditions with or without secondary lung disease, where a higher mean airway pressure could hinder hemodynamics.
To summarize, high-frequency oscillatory ventilation, HFOV, is a lung protective strategy that can be utilized in the full spectrum of patient populations ranging from neonatal to adults with acute lung injury. HFOV is often utilized as a rescue strategy when conventional mechanical ventilation has failed. HFOV uses low tidal volumes and constant mean airway pressures in conjunction with high respiratory rates to provide beneficial effects on oxygenation and ventilation, while eliminating the traumatic inflate-deflate cycle imposed by conventional ventilation. Although statistical evidence supporting HFOV is particularly low, potential benefits for its application in many clinical manifestations still remain. High-frequency oscillation is a safe and effective rescue mode of ventilation for the treatment of acute respiratory distress syndrome, ARDS. All patients who have ventilator-induced lung injury, VILI, or are at risk of developing VILI or ARDS would be suitable candidates for HFOV, especially those who have failed conventional mechanical ventilation.